Dear panelists, speakers, and attendees, on behalf of the Educational Board of the Mega Medical Association and the Egyptian Society of Anesthesiology, I warmly welcome you all tonight to yet another session of the Mega Medical course. It's really a great pleasure and honor for me to moderate this session with Dr. Mahdi tonight. Tonight's session is a mixture of obstetrics and pediatrics with two eminent speakers on board sharing their knowledge and experience. So we've got Dr. Mohamad Ahmad from Canada and Professor Jorge Hidalgo from Belize. Our first speaker for tonight is Dr. Mohamad Ahmad, who is an associate professor of anesthesiology, Western University, Canada. He's also the former head of anesthesia department, chairman of continuing professional education, Department of Anesthesia, Western University, Canada. Tonight, he will shed some light on an extremely important topic in the field of anesthesia, which is the anesthesia for a pediatric shared airway. Dr. Mohamad, the floor is yours.
Thank you, Dr. Ibrahim. Thank you for inviting me, and thank you, Dr. Mahdi, as well. I'm happy to talk about anesthesia for the pediatric shared airway today. This is an interesting topic for us because these are some of the most challenging cases we do at our hospital. So at our hospital, we do around 4 to 6 of these types of cases every week. Some of them are repeat patients coming for procedures, diagnostic procedures, therapeutic procedures. Some of them are quite sick. We also do a lot of adult a lot of adult shared airway surgery, but it differs. When I was training, every airway operation involved an endotracheal tube, but over the last 15, 20 years, we've gone to almost exclusively no endotracheal tube, spontaneous breathing, and truly a shared airway. The objectives today will be to focus on intraoperative management. I'm not going to talk too much about preoperative management, although that's extremely important. We're also going to discuss airway options, discuss ventilation options, discuss the anesthetic drugs that we would use during a pediatric shared airway. And if time allows, I'll discuss some typical types of shared airway procedures that we use. So what is a shared airway? A shared airway is any time that the anesthesiologist has to give up the airway to the surgeon. Because you're operating on the airway, the surgeon has their own needs and we have our own needs and we have to compromise. I'll get into that a little bit later. But this list that you see here is a list of typical types of shared airways. Some of them are amenable to endotracheal tubes. Some of them require no airway device at all. And it's very important to discuss with your surgeon what their goals are. This procedure here is a direct laryngoscopy. It is usually done without an airway at all because the surgeon needs to look at the vocal cords. The vocal cords are right here. Looks at the rest of the airway in an unobstructed manner and to see how this airway is functioning dynamically. If we put an endotracheal tube in there, the surgeon would not be able to do any of that. Now in adults, like I mentioned, these types of procedures are done with an endotracheal tube, and they're commonly done in community hospitals. So in our region, we have a catchment area of about 2.5 million people, and we have around 12 hospitals, and most of them will do some adult shared airway work. But all the children come to our tertiary specialized hospital, a pediatric specialized hospital to do this. And sometimes they come from 3 or 4 hours away. But these, and especially in kids, are high-risk procedures, and so they do require expertise, surgical and anesthetic expertise, specialized equipment, and facilities for post-operative monitoring, pediatric intensive care unit. Luckily, most of these cases are elective, but occasionally you'll have life-threatening emergencies like foreign body aspiration. Some of these procedures are purely diagnostic, such as drug-induced sleep endoscopy for sleep apnea, or laryngoscopy, bronchoscopy for stridor. Occasionally, though, they'll go from being diagnostic to therapeutic just on the spur of the moment. So again, you need good communication with your surgeon what they plan to do. If they plan to just do a diagnostic procedure, it's pretty simple. If they plan to do a therapeutic procedure, example for laser, then your life gets a bit complicated. Some of the considerations we have for shared airway is that we have limited access to the airway as anesthesiologists. So like I mentioned, the anesthesiologist has to make some compromises with the surgeon, and the surgeon likewise has to make some compromises. It requires meticulous planning, and especially requires meticulous communication throughout the procedure, especially at the surgical safety checklist. These are high-intensity procedures. There's lots going on. You have to really pay attention. The surgeons try to work rapidly. There can be blood loss, there can be airway edema, there could be obstruction at any time. So you have to recognize when there's a potential for airway obstruction. And with experience, you actually get pretty good at it. You know what steps are the critical steps that may cause patient deterioration. Because these are pediatric patients, they have smaller airways, and so there's less tolerance for things to go wrong, like airway edema or bleeding. They're also usually sicker patients, so they don't have a lot of reserve. They have a higher metabolic rate, so they consume oxygen quicker. For these procedures, it's also important for the anesthesiologist to have expert assistance. In our institution, we always have residents. They love these types of cases. They sign up as soon as they see them to assist. We also have anesthesia assistants. The reason it's important to have expert anesthesia assistants is because you may be so busy attending to the patient, you can't chart. You may need somebody to do the IVs while you're managing the airway, especially at induction. And you may need somebody to find equipment and hand you equipment as you're dealing with any airway crisis that comes up. So like I said, it's a busy surgery. There's often a large team. We have an anesthesiologist and an assistant. The surgeon often has an assistant. There's usually 2 nurses. People like to see these cases, so oftentimes you have observers. So it's a large team, and you need to clearly define the roles of each person in the team, and you need clear communication. That's the most important part of any shared airway case. You also want to limit communication to what's important and the situation at hand. You don't want any extraneous talking in the background. You don't want any distractions. You want to discuss the backup options for anything that goes wrong and how you're going to manage a crisis. You want to do this beforehand. You want to have everybody know what their role is going to be in a crisis, what they're going to do, and it's just like a cardiac arrest. Somebody has to be the leader, and it's usually the anesthesiologist. Another thing to keep in mind when it comes to airway dynamics is that the surgeon in this situation is also an airway expert, just like you. So you need to understand his or her goals. They usually know a lot about anesthesia, more than the average surgeon would know. And the airway surgeon needs to be in the room if there's any risk of airway compromise or obstruction. So if you had like a foreign body or an airway mass, then the surgeon should be in the room at induction and extubation to intervene with their instruments if there's a crisis. So just as the surgeon has anesthetic expertise over and above the average surgeon, the airway anesthesiologist has to have surgical expertise too. You have to know how to assist the surgeon. For example, when the surgeon is sizing the trachea with an endotracheal tube, you have to know what is the right amount of leak around the endotracheal tube. Usually we say 20 centimeters of water pressure. We don't measure accurately. It takes a lot of experience to determine what an appropriate leak is. You also try to optimize the surgical conditions. So you need to maintain optimal depth and patient positioning. You need to communicate with the surgeon how the current anesthetic depth is going to affect their findings. So that, for example, if they're doing a airway examination for sleep apnea, you have to tell the surgeon when the patient is too light, too deep, because they need that information to know how to interpret the findings that they're observing. And you also have to know the procedure so you can anticipate problems. You need to know the surgical pathologies, the words that come with these pathologies, the associated conditions, the grading systems, the steps of the procedure, and the surgical equipment and how it works. Much more so than almost any other surgical procedure you might be involved in. So for example, you need to know the causes of stridor. So as you can see here, we have 3 columns, all with conditions that cause stridor. You have to be intimately familiar with each of them and how they're managed. You need to know how stridor is graded by the surgeon. So they have a 4-point grading system. When they're talking about the grade of stenosis in their notes or in the operating room, you have to know exactly what that means, because they won't have time to explain this to you. Okay. You also need to know what the specialized equipment is. So this is what's called a Parsons laryngoscope. It's used by ENT. It's very similar to our laryngoscope. It's much more rigid, but it looks like a lot of other instruments you might see in the operating room. This is a rigid bronchoscope. It has multiple ports on it. You need to know what each port is for, where you connect your oxygen supply, where you connect the light source, what's the working channel. You also need to know what works with what, like what bronchoscope will work with what endotracheal tube, or for example, if you put a 4 endotracheal tube in the patient, then they most likely can take a 3.7 standard bronchoscope. But if the patient can only take a 3 endotracheal tube, well, this bronchoscope is not going to work because the external diameter is much larger than the external diameter of a 3 endotracheal tube. So you have to go get a smaller bronchoscope. And when you recognize this, you have to inform the surgeon. This patient took a smaller endotracheal tube than I expected. We need a smaller bronchoscope. So what are the goals of the anesthetic during a shared airway procedure? Well, we want to provide optimal surgical exposure and visualization. We want to minimize coughing and airway reactivity. And throughout the case, we want to keep vigilant for airway problems as they develop or even before they develop, such as obstruction, laryngospasm, bleeding, secretions, vomiting. And our final goal is rapid airway emergence, rapid recovery and emergence. We want the patient to be back to their baseline, especially when it comes to the airway, as quick as possible. Some of the compromises we have to make is that when the surgery is underway, the surgeon is working, there is specialized equipment in the airway, like bronchoscopes, microscopes. The airway may be suspended. And if we need to get to the airway quickly ourselves, we may not be able to, because the surgeon can't just take this stuff out quickly. It takes some time. It's not as quick getting to this airway as it usually is when you run into a problem. Another thing to consider is that your monitoring may not be ideal. For example, your end-tidal CO2 may be absent or unreliable, especially if you're not using an endotracheal tube. Other problems are, and especially relevant to pediatrics, is the patient is exposed. So your ability to keep the patient warm is less so. This usually means you have to put an underbody blanket or a lower body blanket, where normally for an infant you'd want to cover them up as much as possible. The reason the patient is exposed is you need to be able to see the chest and some of the abdomen so you can assess their ventilation. Oftentimes these procedures are done with the room lights off, especially if a microscope is being used. And then the final compromise that I've listed here is the positioning of the patient and the room is not optimal from an anesthetic perspective. I'll get into that a bit now. So the patient's always supine and they have their neck extended to accommodate the surgeon's laryngoscope or rigid bronchoscope. Sometimes the head is turned to the side, but usually it's not. If the airway is suspended, you can't turn the patient, you can't move them in any way because they're fixed to whatever is suspending the airways. We usually use a Mayo stand. Some places use an arm that goes over the operating room table. Also, the table is usually lower than you normally want for airway management, especially intubation. And it's usually turned 90 to 180 degrees away from you, which makes having a longer circuit very useful, so it could reach the patient's airway. As the anesthesiologist, you're usually standing beside the patient. You can't be at the patient's head because that's where the surgeon is. And you need to be able to stand in a place where you can see where the chest wall is moving adequately or not, so you can assess ventilation. Typically in RORs, this is how the OR is set up. The anesthesiologist is standing at the patient's right side. The anesthesia machine is a bit behind us. The surgeon is at the patient's head. They often have an equipment table and an assistant on each side of them. The nurse stands on the patient's left side, and she has her own instrument table on the left side. And there's oftentimes a Mayo stand or an arm here that is used to hold the suspension laryngoscope. So you can see here, if you ran into trouble and you wanted to get to the patient's airway, you would need to move this table and the surgeon would have to get out of your way. You might have to pull the anesthetic machine closer to you so you can manage it. This is an example of a patient having rigid bronchoscopy. The airway is suspended with this Parsons laryngoscope on an arm. This patient has a tracheostomy. You can see the abdomen and the chest are exposed. There's an underbody blanket. In this situation, the anesthetist is standing on the patient's left-hand side, but that part's not really important. The important thing is there's a lot of things in the way between you going from the patient's side to getting to the top of the patient. So it truly is a shared airway. These procedures can vary in duration. It can be as short as 10 minutes, but typically more like 30 minutes for a direct laryngoscopy, including the induction, reaching the appropriate anesthetic depth, the actual procedure, waking up the patient. Other procedures like adenotonsillectomy, managing a post-tonsillectomy bleed, take longer. The longest cases we have are cleft lip and palate procedures. So what are our airway options? Well, the type of airway that we use is dictated by the surgeon's requirements. So if they need to see the vocal cords, then you really can't put anything in the vocal cords. This is different than adults, where because the glottic opening is so big, you can put a small endotracheal tube in the trachea and the surgeon can work around it. But in kids, because their airways are so small, Even a small endotracheal tube interferes with the surgeon's ability to visualize and work on the vocal cords. So our options are generally no airway, an oral endotracheal tube, a nasal endotracheal tube, which can include a laser-safe endotracheal tube, jet ventilation, and a tracheostomy. And I'll go into some of these in more detail right now. Right after the ventilation. Our ventilation options are, of course, dictated by, again, the surgical requirements. So if the surgeon needs to do a dynamic testing, he needs to see how the vocal cord works, then you have to let the patient breathe spontaneously. They can't assess the vocal cord function, for example, for vocal cord paralysis, if you've paralyzed the patient and intermittently ventilating them. Also depends on the type of airway device that you've used. So you could do spontaneous ventilation, which is by far the most common technique that we use. You use jet ventilation, very uncommon in kids for reasons I'll explain shortly. You can do conventional ventilation if you have an endotracheal tube in. You can do intermittent ventilation either through an endotracheal tube where you intubate and extubate the patient as needed, or you could do bag mask ventilation intermittently. There's also apneic oxygenation where you don't actually ventilate the patient, you just apply nasal prongs, and this gives the surgeon maybe 5 minutes at most to do whatever they need to do. Patient's not breathing during this time, so the assessment of dynamic function is limited. Finally, for more complicated procedures like tracheal reconstruction, you require cardiopulmonary bypass or ECMO. We don't do this in our center. We have another center 2 hours away that does. So I'll get into more detail about the modes of ventilation. So for spontaneous ventilation, it's very popular with the surgeon because it gives them optimal access, visualization, and it's efficient. They can work for a long time without getting interrupted. There's no airway device in place. It's best for assessment of the glottis and assessment for dynamic obstruction, also vocal cord function. However, it does require total intravenous anesthesia and some way to deliver supplemental oxygen. Because you are trying to provide optimal surgical conditions, the patient needs to be relatively deep. However, the deeper they are, the worse their ventilation is going to be. So you have to balance depth of anesthesia versus minute ventilation. You can't monitor end-tidal CO2 very accurately, so you may have no idea what the patient's level of CO2 is. They could be severely acidotic, and you wouldn't know it. Oftentimes, these patients have respiratory issues at baseline, and they have poor ability to respond to rises in CO2. They could be CO2 retainers, such as patients with sleep disordered breathing or sleep apnea. Spontaneous ventilation is especially challenging in really sick kids because they fatigue easily, especially infants, and they'll develop an acidosis. You can reduce the amount of TIVA that you need by spraying the vocal cords and the trachea with local anesthetic. Another modality is jet ventilation. I'm sure you've all heard of this. It's very common in adults, but very uncommon in children because of the risk of barotrauma and air trapping. Also in the pediatric airway, there's not a lot of space to put a jet ventilation catheter. There's multiple routes you can use for jet ventilation. You can put a supraglottic catheter or cannula and direct it at the vocal cords. You can do a small endotracheal tube, or you can do it through the rigid bronchoscope. That's called the transglottic or tracheal approach. You can also do transtracheal, which is a tracheostomy or a cricothyroidotomy. Problems, again, requires total intravenous anesthetic, and you can't monitor end-tidal CO2 or airway pressure. Now, there's multiple devices in the market available to assist with jet ventilation, but not many of them are optimized for kids. There's also the apparatus that you use to deliver jet ventilation can be either high frequency, which is 10 hertz or more, which means more than 10 breaths a second, or low frequency, which is usually a handheld device that I'll show you on the next slide. The nice thing about jet ventilation is it's laser safe. Now this is a jet ventilating device. You can see here that this hose would hook up to your high pressure oxygen source. You have a regulator here that limits the pressure that goes into the patient. You have an on and off valve here to deliver the breaths, and you have a way to connect this to whatever the distal end is going to be here, whether it's a endotracheal tube, bronchoscope, IV catheter. So I'm sure you've all seen this in the past. Another option is controlled conventional ventilation. So this is ventilation through an endotracheal tube. It requires a tube. Usually we use smaller than predicted tube for that particular patient. It allows you to use paralysis. However, the problem with an endotracheal tube in the airway is that it hinders the surgeon's views. And if you're using laser, the endotracheal tube may be combustible. I'll talk about laser safe tubes in a minute. Advantages of conventional ventilation is that you can control the rate and the volumes and PEEP, which allows you to control CO2 and oxygenation. This is the best option really for very sick kids, kids that are at risk of aspiration, such as kids with the reflux or full stomach. It also protects against aspiration of blood if you get airway bleeding, and it allows you to bypass obstructive lesions in the airway. Now, if the endotracheal tube is going to hinder the patient's view, again, you can use intermittent intubation and ventilation, or you can do mask ventilation as the surgery and patient saturations allow. If you're doing lasering, you can use a laser safe endotracheal tube, but it's important to keep in mind that laser safe endotracheal tubes have a larger external diameter than regular endotracheal tubes. So these are laser safe tubes. They're made out of metal, but they're thicker than the equivalent non-laser tubes. This tube here has a cuff. It actually has two cuffs. And the reason it has two cuffs is if the laser punctures one of the cuffs, you can inflate the other cuff. Usually when we're using cuffed laser tubes, we inflate the cuffs with water that's tinted blue so we can see if the cuff has torn. And then we would just inflate the second cuff. Final option for ventilation that I'm going to talk about is no ventilation, or what's called apneic oxygenation. This involves delivering oxygen in a patient who is completely apneic through nasal cannula or orally through an endotracheal tube that's sitting in the mouth. Again, you can't deliver an inhaled anesthetic this way because you don't have an airtight seal. So it requires total intravenous anesthetics. And to stop breathing, sometimes you need either high-dose opioids, such as remifentanil, or muscle relaxants. Disadvantage of apneic oxygenation is that it limits working time for the surgeon. However, it provides a completely still field. So if the surgeon doesn't want the vocal cords moving or doesn't want any movement at all, then this is your mechanism of choice. A surgeon can work. If the patient desaturates, then you can bag mask ventilate. This is really the optimal technique for lasering because the vocal cords aren't moving, and it's laser safe because there's nothing combustible in the airway. So how do we induce a patient in practical terms? Well, first we do the surgical safety checklist before the patient goes to sleep. Sometimes we'll do it with the patient's parents in the holding area. And we do a detailed step-by-step plan so everybody knows exactly what the anesthetic steps and the surgical steps are going to be. There shouldn't be any surprises. Again, if there's a risk of airway obstruction, the surgeon should be in the room at induction. And recent studies have shown that a propofol induction is safer than sevoflurane induction. It provides better operating conditions for the surgeon because there's less airway reactivity, less risk of laryngospasm, less bronchospasm, less coughing, and overall a nicer recovery for the patients. This means you have to do an awake IV, which may be challenging. And once you finish your induction, you're in the maintenance phase, then you can hand the patient over to the surgeon. And you have to decide when the patient really is ready for the surgeon. And various guidelines would suggest that they're ready when the respiratory rate is half of the awake respiratory rate, or there's lack of response to sternal rub. But most of us use just regular intubating criteria for an inhalation induction. When there's midline eyes, 2 MAC of anesthesia, or sinusoidal breathing. How do you maintain the anesthetic? Well, there's multiple different medications available. Dexmedetomidine is relatively new. There's not a lot of experience with it. It does have drawbacks such as bradycardia. It takes a while to get a loading dose in, and wake-up time from dexmedetomidine is longer than from propofol or sevoflurane. Also, ketamine is a potential option. So all of you, I'm sure, are familiar with ketamine. Run it as an infusion. Problems with ketamine are production of secretions, which may require suctioning, and again, delayed emergence. Midazolam, a benzodiazepine. I can run it as an infusion as well, but problem with that is delayed emergence. Propofol is what we would use 90% of the time. Again, you're all familiar with how to use propofol as an infusion. Here I've put 50 to 250 micrograms per kilogram per minute, but some of my colleagues will use up to 400 micrograms per kilogram per minute, especially if they're using just propofol as the sole agent. Problems with propofol, again, respiratory depression. You can lower the propofol dose by running a remifentanil infusion, but again, you're risking respiratory depression. So you have to keep a close eye on the patient's breathing. Watch their chest and abdomen, the respiratory rate, and watch for apneas. Finally, you can use sevoflurane, but you have to have a way of delivering it without contaminating the room. And if your patient's breathing spontaneously and you use sevoflurane intermittently, you'll get fluctuating levels of anesthesia. So generally, a balanced anesthetic is the best. So the current literature would recommend a combination of dexmedetomidine, propofol, and remifentanil. Some special things to consider during a shared airway case is there's always the potential for acute obstruction. You have to be very vigilant, recognize and communicate this early to the whole OR team. When it happens, you need to simultaneously diagnose and manage it. Now, your options for dealing with airway obstruction are stop the surgical stimulation. Sometimes that's sufficient, especially if the surgeon is working around the vocal cords. You may need to deepen the anesthetic. You may need to lighten the anesthetic. If there's any blood or secretions in the airway, that may cause laryngospasm. You section that. If it's a rapid, severe desaturation, then the surgeon can often intubate quickly, and they usually have an endotracheal tube on their instrument tray, and they can intubate within seconds. They have the airway exposed. They can see the vocal cords clearly. They can intubate. You can attach your anesthetic circuit and ventilate the patient until the acute crisis resolves. However, sometimes that's not adequate and the surgical instruments need to be removed and you can bag mass ventilate. Very rarely an LMA will help, but if there's instruments in the airway, of course, an LMA, it can't be put in right away. Other things to think about are atelectasis. Now, the longer the case goes on and the deeper the anesthetic, the more and more atelectasis the patient will develop. Every patient gets atelectasis as soon as you put them off to sleep. problem here is that if your atelectasis is severe, you may need to actively ventilate the patient. So this may reduce the working time that the surgeon has. Sometimes the atelectasis is severe, but you need to continue the surgical work. You may need to just tolerate a lower saturation, and you have to decide how low is too low a saturation. Usually, when we start these cases, we'll aim for a saturation no lower than 92%, because that's where the oxygen hemoglobin dissociation curve starts to get steep and desaturation is rapid below that point. But sometimes you'll have to tolerate a saturation in the low 80s just to allow the surgeon time to work. Atelectasis is worked with apneic ventilation and intermittent ventilation. It's not so much a problem with spontaneous ventilation or controlled ventilation. And sometimes you might need to do recruitment maneuvers at the end of the case if the patient's saturation haven't improved because of the atelectasis. Other problems are airway trauma and edema. Now, the more work you do on the airway, the more edema you're going to get. You can also get trauma like bleeding or burns. So you have to watch for this, and it may limit the overall amount of work the surgeon can do. It can also limit your ability to extubate the patient. You can reduce edema by giving big dose of dexamethasone, 0.5 milligrams per kilogram or more early in the case. And this is quite a bit larger than our antiemetic dose. And oftentimes the patients will get 3 or 4 doses of dexamethasone at the same strength, 0.5 milligrams per kilogram for the next 24 hours. You can also reduce edema by limiting IV fluids and limiting Trendelenburg position. Post-operatively, these patients are often recovered in the sitting position to try to reduce the edema. Another special situation I want to talk about is Down syndrome. Kids with Down syndrome have frequent ENT problems such as sleep disordered breathing. They have eustachian tube dysfunction, so can get chronic otitis media. This is treated by adenoidectomy. They can also have subglottic stenosis and macroglossia. So some of these patients come to the OR quite frequently for ENT-related procedures. Now, our biggest concern with them, other than potential difficult intubation, is atlantoaxial instability. Our current guidelines in North America do not routinely recommend C-spine X-rays, but in our hospital, we have been doing them for kids getting ENT procedures because of the extremes of neck positioning that they require for a lot of procedures, such as tonsillectomy or rigid bronchoscopy. And I'll show you this picture again. You see how much this child's neck is extended. If this was a patient with Down syndrome, we would be severely worried about this amount of neck extension. If we do the C-spine X-rays and we see that there is atlantoaxial instability, then this would not be an appropriate procedure for this child. Post-operatively for shared airway procedures, we prefer that the patient be woken up in the operating room and the airway function assessed, looking for signs of airway obstruction, respiratory distress, or potentially even respiratory failure. Occasionally, you have to re-intubate these patients after emergence. You want to try to avoid your opioids if you can. And here I mean about long-acting opioids or even fentanyl, because they'll delay wake up and they'll cause respiratory depression for hours post-operatively. Most of the procedures that we do in shared airway are not painful. Really, the one that's most painful would probably be tonsillectomy, and it's standard to give fentanyl or morphine for tonsillectomy. But our surgeons are moving away from that instead, depending on Tylenol and ibuprofen. However, for other airway procedures such as bronchoscopy or sleep endoscopy, there's no pain after the procedure, so they don't need any long-acting opioids. Also, for postoperative care, you need to be vigilant for airway edema. And like I said, they're recovered sitting up. They get multiple doses of dexamethasone. And it's very important to tell the parents about this before you take the patient to the operating room. The parents are expecting that their child is going to go to the operating room and have their airway fixed. So they're often surprised and worried when they hear that the stridor, for instance, sounds worse post-operatively, or the snoring is worse post-operatively. And you have to reassure them pre-operatively that this may happen, not to worry, that usually it'll last around 12 hours, usually no more than that, and their child will be better afterwards. It's just airway edema from the procedure itself that's causing this increased stridor or snoring. Now, when it comes to deciding who gets admitted and who can go home the same day, criteria are not firm, especially not in North America. But generally at our hospital, we admit anybody that's under 3 years of age for postoperative monitoring. And some of them will require admission to the ICU, especially patients who are having extensive work done on their airway, kids with Down syndrome, kids with moderate to severe sleep apnea. And if you have a step-down unit, that might suffice, but our ICU functions as our step-down unit. And they're usually quite happy to take these patients. Now, if you have criteria at your hospital, that's great. But if not, then I would really encourage you to develop them so that you're not having to decide on a case-by-case basis on the day of the procedure who's going to be admitted, who's not, especially when you need to make arrangements beforehand for a bed to admit a patient to. The worst situation would be to do an airway operation, decide that you need to admit the patient and no arrangement's been made for that, and there's no bed available. Okay. I'll sum up by saying that, again, communication is really important. And if there's any doubt in your mind, then you should definitely ask. Ask your surgeon. You always need to know what the airway plan is going to be. You don't want to intubate a patient and then find out, well, the surgeon really wanted spontaneous ventilation with no airway in place. This is a problem, especially if you've paralyzed the patient or given opioids. Another example is giving steroids. You don't want to give steroids for somebody who has suspected lymphoma or other tumors, because this will cause tumor lysis syndrome. So for example, if your child's coming for a unilateral tonsillectomy, well, that's probably not for tonsillitis or sleep apnea. That's probably a part of a lymphoma protocol. Another thing to think about is non-steroidal anti-inflammatories. Most of our surgeons will absolutely not want patients to receive ketorolac because of its COX-1 inhibition and interference with platelet function, but they will allow ibuprofen, which has much less COX-1 specificity and less interference with platelet function. What you don't want to do is give a patient ketorolac, your surgeon not knowing and having inoptimal bleeding control intraoperatively, resulting in a postoperative bleed. Another thing to think about is whether the surgeon wants to do neuromuscular monitoring. This is important, for example, for vocal cord function assessments. You don't want to paralyze the patient, have the vocal cords not move, and then the surgeon tell you, well, I need to see the vocal cords move because I need to assess their mobility. So things like that. So if you have any doubt in your mind, especially if you're not familiar with these procedures or familiar with the surgeon's plans or preferences, then you need to ask. And that is the end of my planned talk. If there is any questions, I'll be happy to take them, but I'll hand over to Dr. Ibrahim.
Uh, Thank you very much, Dr. Mohamad, for your presentation. Really, that was very informative. Yes, I've got some questions for you. So, first question, if a muscle relaxant is needed, which one would you prefer?
Well, that will depend on how long the duration of muscle relaxation is required. So if it's just a few minutes, then succinylcholine would be reasonable, but you have to keep in mind that you may not be able to repeat the dose of succinylcholine. You could use a small dose of rocuronium if longer muscle relaxation is required. Not an intubating dose, you could use half an intubating dose. So for example, if you used a 0.6 milligram per kilogram standard intubating dose, you should be able to reverse that in about 20-25 minutes. If you used half the intubating dose, you may not get complete paralysis, and you could probably reverse that at any time. I'd say you should probably wait 10-15 minutes before you try to reverse half an intubating dose, or 0.3 milligrams per kilogram. We do have longer acting muscle relaxants, but generally we wouldn't use those. Cisatracurium, pancuronium. Yeah, so really we're limited to succinylcholine and rocuronium. A small bolus of remifentanil can also produce apnea if that's what you're aiming for.
Okay, thank you for that. How to manage a case which developed surgical emphysema in the PACU following tonsillectomy and affecting the airway?
So the patient had a tonsillectomy, had postoperative emphysema.
Yes.
So I'm sure you're all aware what the concern here is, that you could have ascending subcutaneous emphysema reaching the level of the airway and making airway management very difficult. So this would require a return to the operating room potentially if it's severe. You probably don't want to manage that in the recovery room, especially if the patient can be transferred. If the patient can't be transferred, well, then you're limited. Your hands are tied. But you want to call your surgeon back, and you want to optimize your conditions for re-intubation. But early re-intubation is very important here. Okay. And try to minimize things that would make the subcutaneous emphysema worse, like coughing. Don't sedate the patient if you can avoid it before you're ready to manage the airway.
Okay, thank you.
But yes, it's important to recognize it early. Make sure your staff are well educated in recognizing it, are vigilant for it, and know who to contact if they suspect it.
Okay, thank you for
And
that.
I should also mention that subcutaneous emphysema can occur during jet ventilation.
Yeah.
That's one of the risks.
Okay. What is the role of the Thrive and the high flow nasal oxygen in a child for a difficult shared airway?
Thrive is a new device that's developed for delivering high flow nasal oxygenation. It looks very promising. I know in some centers they're using it routinely. We haven't used it. It hasn't been approved in North America, from what I recall. So I don't have any firsthand experience on it, but from what I've read, it looks very promising. It can increase the apneic time and allow the surgeon to work longer. And it appears to be quite safe.
Okay, thank you. What is the best in induction for a case of choanal atresia?
Choanal atresia?
Atresia, is it intravenous or inhalational?
The airway reactivity is less so with IV induction. But oftentimes these kids are quite young and an IV may be difficult. You may upset them. Choanal atresia, when they're crying, they can't breathe through their nose, so that alone may make them desaturate. Um, Choanal atresia is a bilateral obstruction of the nasal passages. Usually, it's diagnosed when the child is feeding initially. So when they're feeding, they can't breathe through their nose, and kids are obligate nasal breathers. That means they have to breathe through their nose when they're feeding. So they get blue, they get cyanotic when they're feeding, but usually when they cry, they get pink. So that's like the typical way of how choanal atresia is diagnosed. But in our center, we tend to do inhalation inductions, have an IV in place before we even touch the airway, because if things go bad, then you need that IV in place to resuscitate the patient. And we have lots of help in our operating room. So one person can manage the airway, another person can manage the IV. So that's what we're accustomed to and pretty comfortable with. If you were working on your own, though, it may be more useful to have an IV in place beforehand, so you don't have to worry about it at induction. If the patient runs into trouble, you already have your IV in place. You can give atropine, you can give your muscle relaxants if you need it. But in either case, the patient won't be able to breathe through their nose. So if you're doing an inhalation induction, you have to maintain a patent oral airway.
Okay. What is the role of video laryngoscopy, and which one would you choose?
For video laryngoscopy, um, we don't use it routinely for kids. We have it available. I'll discuss the ones that we have available. We usually like to use straight blades. That has a high success rate, especially in younger infants. And once they're over a year, 2 years, most of us will switch to a curved blade, a Macintosh blade. Now, for the patients with suspected difficult intubation, we will have a video laryngoscope in the room. And we might go to that first, especially if we have documentation of previous difficult intubation or the child has a syndrome. And our preferred one is the GlideScope, the GlideScope spectrum system. So they're called low pros as well, and they come in size S1 and S2. They're very curved compared to the old GlideScope, which was straighter and really no better than a regular blade. The old GlideScope was no better than a regular blade. But the newer one is much more curved, much better for an anterior airway, which is what you'll usually run into in a child. And we've had a lot of success with that. Even in kids that historically have been very difficult to intubate, we've been able to intubate them on the first attempt. And because it has a separate screen, everybody in the room can watch the intubation, including the learners, the teachers, the surgeons, and you can recognize abnormal anatomy. You can record, you can take pictures. The other systems that we have are a Bullard scope, which it's like a rigid bronchoscope with a curve, and you're looking into an eyepiece. That's not very useful because you can't actually see the endotracheal tube going through the vocal cords. And finally, we have a Storz CMAC system, which is a lot like the GlideScope, except it's a straight blade rather than a curved blade with a 30-degree angulation. And we've had that for about a year, and it works extremely well in infants because, again, everybody in the room can see it. You're looking at an angle, so if it's an anterior larynx, and it's straight, which is the critical part of it compared to a GlideScope. It allows you get to that anterior larynx better than a GlideScope. However, the GlideScope is much more affordable. It's about a third of the cost of the Storz video laryngoscope. So we have about 4 GlideScopes and 1 Storz video laryngoscope. The CMAC, the one that's also called CMAC.
Okay, thank you. One more question. Patient relative refunded to tracheostomy, but patient is difficult intubation. Maybe I can't intubate, can't ventilate. What would you prefer?
So you've gotten the patient to sleep, and you have an unanticipated difficult
Um,
intubation,
I mean,
or you have.
the question is not clear. This is just.
Okay. Well, there's two scenarios. You could have difficult difficult to intubate, difficult to ventilate,
Yeah,
already asleep. So that's an emergency.
yeah.
So you need to work quickly. You need to let everybody in the room know. You want to get your airway adjuncts available: oral airways, stylets, bougies, video laryngoscopes. Try to ventilate the patient. Um, but you don't have a lot of time in a child because they desaturate very quickly and get bradycardic, and then arrest. So in an adult, where you might have like 5 minutes to do something, in a kid you may have less than 1 minute. So a cricothyroidotomy would probably be the best option in that situation, preferably done by the surgeon because they'll have more experience. Um, it's hard to identify the cricothyroid membrane in a child. Now, if you have, on the other hand, a patient that you anticipate will be difficult to intubate, difficult to ventilate, but haven't put them to sleep yet, well, that gives you more options. So you can do an awake tracheostomy, which is possible in kids. You can use light sedation, local anesthetic, um, and you can sedate with things that won't take away the airway reflexes, such as dexmedetomidine or ketamine. You probably don't want to use propofol because propofol will cause airway obstruction. It relaxes the airway more than other IV anesthetics. You could try an inhalation induction, but again, you may risk that you reach a point where you can't ventilate or intubate, and then that becomes a crisis. So my recommendation would be to run a dexmedetomidine infusion, local anesthetic, and awake tracheostomy in that situation. But I would say it's an extremely rare situation, that you know that the patient not ventilatable, not intubatable ahead of time. Because they lack cooperation, you cannot you can't just do an awake look, for instance, or do an awake intubation fiber optically in a kid. I think when you anticipate a difficult intubation in a kid, you have all your airway equipment ready, you have your surgeon ready. And what we typically do is do an inhalation induction, keep the patient breathing spontaneously, do a laryngoscopy, one laryngoscopy to assess the difficulty, and then back off early and then come up with a plan. If you know the patient works, if an LMA works well in that patient, you can do a fiber optic intubation through the LMA. You could do a fiber optic intubation with somebody else doing a laryngoscopy. That works well. Or you could do a rigid bronchoscopy where the surgeon just makes the airway conform to their laryngoscope.
Okay, thank you very much, Dr. Mohamad, for